Good morning. It's a pleasure to be here, and I'd like to thank Mark for the opportunity to speak with you this morning, and we would like to thank all of you for being here for the first talk of the morning and fighting the local traffic. So the members of the vascular anomaly team, the core members are Dr. Bhupender Yadav, who is our interventional radiologist, Dr. Phil Gazzetta, who is our clinical director and started the Multidisciplinary Vascular Anomalies Clinic, myself from Pediatric Otolaryngology, and Dr. Albert O. from Plastic Surgery. And Albert and Phil will be talking to us as well today. Our Vascular Anomalies Clinic meets on the fourth Tuesday of every month as a group. We also see patients and follow up independently on an individual basis. We think that the multidisciplinary approach is very important because it allows a combined strategy for treating these patients who have very complex issues, and it's nice to blend the different disciplines together for the benefit of the patient. We have ultrasound and Doppler available in the clinic. We, of course, can obtain MRA and CTAs and MRs and CTs, as we'll discuss. We have two investigational studies that are enrolling patients. The first is an NIH-funded prospective study that compares the use of propranolol, which you've all heard about probably for treating hemangiomas, versus the age-old prednisolone therapy, and comparing the outcome, the efficacy of treatment, and the tolerance of the two medications. And Albert will talk briefly more about that. And we also have Picibanol, or OK432, sclerotherapy study for treating macrocystic lymphatic malformations.
Thank you and good morning. The Vascular Anomaly Center at Children's National Medical Center is definitely very honored to be part of this session. My topic today is going to be about hemangioma of infancy. This is one of my favorite slides, actually borrowed from my mentor, Dr. John Mulliken at Children's in Boston. And I like this because it really illustrates the so-called cloud of confusion that surrounds vascular anomalies. A lot of these terms that you see are such as cavernous hemangioma or cystic hygroma are terms that are now considered outdated and shouldn't be used any further. Instead, due to the groundbreaking work of Dr. Mulliken and others, the vast majority of vascular anomalies can now be broken down into two major categories: tumors and malformations. And as you can see, the field of vascular anomalies involves a multitude of different disciplines. As I mentioned, the category can be broken down to tumors and malformations, but for the purposes of today, I'm going to be focusing on one simple topic, the infantile hemangiomas. So what is hemangioma of infancy? Well, the truth is we still don't know. Despite all of our research and all of our studies, we have yet to really discover the etiology of why hemangiomas happen. We do have a number of clues, however. We know that hemangiomas are much more common in the female gender. As well, prematurity is highly associated with hemangiomas of infancy. Caucasian race has been associated, and intrauterine trauma that is mostly associated with chorionic villus sampling has been linked to hemangiomas. And we also know that hemangiomas can occur both as an isolated phenomenon or as well as with other associated anomalies. As I mentioned before, there definitely seems to be some role of the placenta with hemangiomas as elucidated by the chorionic villus sampling studies. We know from molecular studies that the cells from hemangiomas are monoclonal endothelial cells, and we know that they have many markers such as GLUT1, myrosin, and Lewis Y antigen that are shared with the placenta. More sophisticated analyses have demonstrated that the molecular signature of hemangioma of infancy and placenta tissue are nearly identical. As you all know, the presentation of hemangioma of infancy is clinically very heterogeneous. Classically, we see that the hemangioma will begin to grow at around 4 to 8 weeks of age. If you question the parents, however, you will often find that there was some type of small lesion, a blush perhaps, or something that was noted at birth. But the growth usually doesn't happen for a couple of months. And then the hemangioma will enter the classic proliferation phase, which lasts anywhere between 3 to 18 months. And then, as you all know, the involution phase will set in. The hemangioma will slowly start to involute, go away. This is some classic pictures of a child who had no intervention whatsoever with any type of medical or surgical therapy. The baby pictures, you can, well, not baby, but young baby pictures show the large hemangioma in the right cheek. At around 3 years of age, you can see how the color has changed. It's gotten less turgor, it has less turgor, and at about the age of 7 or 8, you can see that the hemangioma has involuted nicely. Nevertheless, against what the old saying, that is that, most hemangiomas, 90% of hemangiomas don't require any treatment because they just simply go away. We're finding that this is probably not true, and probably as many as 50% of hemangiomas of infancy do require some type of treatment at some point in the child's life. So in these patients with hemangiomas, who needs further workup? Who can be watched and who can't be watched simply? Well, I think if there's any type of unclear diagnosis, then that warrants further investigation. Hemangiomas that are also found in this beard distribution require further workup, as there is an association with pharyngeal and hemangiomas in the throat. Lumbosacral hemangiomas have been associated with anomalies of the spinal cord, and patients that have multiple cutaneous lesions, the latest study showing that more than 4 lesions have a much higher incidence of having liver hemangiomas and other intra-abdominal hemangiomas. And as you know, there are a number of special associations and conditions such as PHACES Association and sacral syndrome. I won't go into all of those in detail, but I will talk about probably the more common one that you may see in your practice, and that is PHACES Association. I think everyone's familiar with the acronym P, posterior fossa malformations, H, hemangioma, A, arterial anomalies, C for cardiac issues, I, anomalies can also be seen, and issues with the sternum can be seen. And this PHACES Association is often underdiagnosed and missed. Here's a classic picture of a baby at birth taken by the parents. Nothing abnormal was noted, but when I got this picture from the parents later on, I think if you look carefully, one can see this area just above the right ear where there are some abnormal veins and a little difference in the skin color. At about 1 month of age, the patient presented to our plastic surgery clinic with an open wound in the posterior neck, and seeing this with the surrounding skin changes immediately prompted us to obtain further studies. And as the MRI showed, this child had a number of intracerebral anomalies that required fairly sophisticated management. So treatment options for hemangioma of infancy are myriad and somewhat confusing. As Dr. Baumann alluded to, the kind of age-old therapy of corticosteroids is well known. It's well regarded despite the lack of really any randomized controlled trials. Typically, one should see a response within the first couple of weeks after starting steroids. Many of you have probably heard of the so-called rule of thirds, in which 1/3 of hemangiomas will begin to involute, 1/3 will at least stop growing, and 1/3 will not respond. I think it's probably a good general rule to follow, but I think what we usually see in practice is probably more like 40 to 50% have a very good response, and maybe a smaller percentage will just stop. And in general, most hemangiomas do respond to the steroids. However, because of the adverse effect of steroids, including both local and systemic effects, steroids have been called into question, and there are other therapies that are considered. Surgical treatment of hemangiomas is also first line for certain areas, particularly in the periorbital region, nasal tip, around the ear, and other anatomically sensitive locations. Here are some pictures of a young baby with a large hemangioma of the left upper eye. You can see at the time of the operation the removal of the hemangioma, and the post-op follow-up at a few weeks is looking quite good. Another child with a hemangioma of the nasal tip, which was surgically removed through an open rhinoplasty type approach. As you can see, the reason why we do this is because if that hemangioma is allowed to grow, it will distort the nose and cause permanent changes that are actually very, very difficult to fix later on. Finally, here's a picture of a young baby with a large hemangioma of the arm, which we initially were inclined to just observe, but began to bleed and break down, and eventually underwent surgical treatment with a circular flap closure. And as you can see at a 1-year follow-up in the bottom picture, the scar is actually quite acceptable, and the child went on to do well. Other second-line options include pulse dye laser, interferon alpha, vincristine cyclophosphamide. The problem with a lot of these second-line therapies is that many of them haven't really been studied, such as PDL, and interferon alpha and vincristine cyclophosphamide often have side effects that are worse than the steroids, and so they are usually reserved for refractory cases only. And I think this is part of the reason why there's so much excitement about beta blockade. The use of beta blockers in hemangiomas of infancy was actually discovered accidentally in France when patients were placed on beta blockers for cardiac failure associated with large hemangiomas, and they noted that there was a significant involution of the hemangiomas. And so a number of centers have shown case series with good results from the use of propranolol. No one knows the mechanism of how this works, but it's theorized that it has something to do with the obvious effect of beta blockers on endothelial cells and vascular structures. The adverse effects of propranolol are also less than those associated with steroids. And so, again, I think this leads to the kind of excitement that goes around with the potential use of propranolol. As Dr. Baumann alluded to earlier, we are involved in a multi-center NIH-funded trial looking at propranolol versus prednisolone. Our inclusion criteria there are several, but in general, any infant aged between the 2 weeks to 5 months can be eligible for the study, and we are currently enrolling patients. Some pictures of patients who were placed on propranolol. The photograph on your left-hand side is a picture of a large hemangioma of the arm with an open wound. The middle picture is actually what it looks like after simply 24 hours of propranolol. And it's a little bit difficult to make out from the picture, but I think you can see the progression of how the hemangioma is a little bit less red and a little softer and less tumor-like in terms of its projection. And the wound has also started to clear up. The last picture on your right is actually just at 1 week. Here's another baby with, as you can see, the slight blush noted at birth, growing into a full-blown hemangioma and a couple months of age. The patient was placed on propranolol, and at about 1 year, we see a very good result. Again, would this have happened without the medication? It's hard to tell, and so this is why we're involved with this multi-center randomized controlled trial to really see the effects of propranolol. So in conclusion, hemangiomas are very common. Each of you will see them frequently in your practices. The classic history and examination will often yield a diagnosis, and a lot of hemangiomas can be observed. But as we have shown, there are a number of hemangiomas that do require some type of intervention, either because of the anatomy or the number and location. Treatment options include both medical and surgical therapies. Steroids are still considered the first-line therapy, but as we discussed, beta blockers are becoming more and more popular and being more studied. Nevertheless, I think we would all benefit from further studies, and hopefully, if any of you have patients that fit the criteria, we would love to enroll them in our trial. Thank you very much.
All right, I'm going to spend a little time talking to you about some anomalies that the pediatric general surgeons are asked to see, but frequently some of these are initially seen by the pediatrician. I think Albert has done a very nice job explaining to you that there's a lot of problems with proper nomenclature. So I'm going to go a little bit into some of the areas of arteriovenous malformation, some aneurysms you might see after an injury, venous malformations, and then talk just for a minute about liver hemangiomas because there's a lot of new information about that. So AVMs are most commonly seen in the head and neck, usually noted at birth to be a bluish discoloration beneath the skin, and frequently they're misdiagnosed as a hemangioma. You can tell it's not a hemangioma, though, because they don't get to that stage generally in which there's a purplish color to them. There seems to be a rapid flow through the lesion, and as the child grows, they grow with the child. They don't get bigger. They don't have this period of proliferation that Albert talked to you about, but they just seem to grow with the child. The key here is physical exam is usually the way this diagnosis is made. If there's local warmth, there's the presence of a thrill, or you put your stethoscope on it and it has a bruit, it's an AVM. It's not a capillary hemangioma. Now, these AVMs can go through various stages, and I'm not going to spend a lot of time on this, except to explain to you that generally these things are not cared for in infancy unless the patients have evidence of congestive failure secondary to that, which generally is not the case at birth. But there is a progression, and usually this takes years. So when we identify a child with an AVM, even though we may see them at 6 months or a year of age, frequently these children do not undergo their appropriate procedure until they're a few years of age. The thing that's most important about the AVMs is these lesions tend to be much more complex than you think they are just based on physical examination. So that child with a little bluishness over the eye, you think, well, that can be pretty easily managed. In fact, frequently there's a lot of feeder vessels, and for that reason, although some of these patients are candidates for surgery, most of them require embolization, interventional radiology. So we're very careful about evaluating these children. We just don't just jump in and operate on them because they can be much more complicated than that. We also see AVMs that are iatrogenic. One of the things that we know about iatrogenic AVMs, such as arteriovenous fistulas that are put in patients with renal failure, in children, if they have an AVM, there's limb growth discrepancy. In other words, for reasons that are not entirely clear, you can see in this picture, this child has had a AVM placed in the left groin, and you can see the left leg is not just, it's not edematous, it's actually bigger. The knee is longer, the leg is longer, the bone is bigger, and there's some evidence that that has to do with increased venous pressure on the side with the AVM. So if you see a child such as this is a child who'd had a manipulation of the arterial system on the right side, and this is particularly common in patients who've had cardiac catheterizations. If they get an iatrogenic AVM, you can see that this child's right leg is clearly bigger than the left leg. This child's 1 year of age. And it's because there was a arterial stick that was done in the groin which caused this AVM. So if you have a child in your practice who's had cardiac catheterization and the mother says, you know, this leg looks a little bigger, and then you have a sense that there's a thrill in that leg, that's the reason for it. And again, this is something that requires treatment, usually surgical intervention. This is a child who fell on a piece of glass, and the bleeding stopped, so nothing was done. The patient came to the emergency room about a year later and said, gee, I've got this swelling in the hand. The thought was that this might be an abscess, and in fact, it was a traumatic or a false aneurysm. And in this case, rather than doing embolization, it was just excised. Now, the venous malformations, similar to the AVMs, generally present at birth. They're bluish, they're soft, they're compressible. They don't look like the purple hemangiomas that Albert just spoke to you about. They grow with the child. Most of them are in the skin and subcutaneous tissue. They used to be called cavernous hemangiomas. They're not hemangiomas. They're venous malformations. Sometimes they can develop clots which become painful. So this child, you can see this is an older child. This is not a baby. If the mother says, yeah, it's been there forever and it's grown with the child, then think venous malformation. This is another venous malformation of the lip that was treated by the plastic surgery service. And again, these are lesions that may require sclerotherapy, but depending on their location, may be better treated with surgery, as this child was with an excellent result. Now, one of the venous malformations may also be associated with the Klippel-Trenaunay syndrome. As you recall, this is a capillary lymphatico-venous malformation. They're obvious at birth. There's often soft tissue and skeletal hypertrophy. Frequently, it's only in one limb, but it may be in both, as in this child. The interesting thing about this, and Albert mentioned this, some of the patients who have hemangiomas or these venous malformations with capillary hemangiomas may develop a complex that you may be familiar with, the Kasabach-Merritt syndrome, in which the child has a significant hemangioma, has congestive heart failure, and also has thrombocytopenia. Some of these can become very extensive and require extensive surgical procedure, but many of them are less severe. But there are ways to treat these children long-term successfully. There's also a unusual anomaly called the blue rubber bleb nevus syndrome, and these are patients who develop with frequently multiple what look like blueberries on their bodies. They increase in frequency, but most importantly, they also have GI venous malformations that lead to bleeding in the GI tract, and that's generally when the general surgeon, somebody like me, gets involved in their care. I'm just going to spend 2 minutes speaking to you about liver hemangiomas because this whole issue has changed entirely in the last 3 years. So if you think it was confusing talking about capillary hemangiomas, when we talk about this is entirely different. The people at the Vascular Anomalies Clinic in Boston and in other places have redefined these. And now we don't use the terms hemangioendothelioma, capillary hemangioma. None of those terms are used anymore for these lesions. They classify them based on how many there are. They're focal or multiple or diffuse. So most liver hemangiomas are focal. Most of them are asymptomatic. Most of them require no therapy. In fact, I now see 3-4 patients a year who the mothers are diagnosed with liver hemangiomas in the fetuses prenatally. So they don't need to freak out about this. Most of the time we don't have to do anything with them. We just watch them. Now, some of these hemangiomas certainly have additional problems, just as with the patients with the Klippel-Trenaunay, some of them may go on to this Kasabach-Merritt syndrome, in which they'll have congestive heart failure and may even have significant thrombocytopenia. The problem becomes when they have a big liver mass, they're difficult to diagnose what the cause is. This is such a child who was obviously a newborn because it has an umbilical vein catheter in which there was significant abdominal compartment syndrome. Most of these patients can be successfully treated with corticosteroids, but this is a benign condition with a significant mortality rate. These are the ones that are most difficult to treat. This is a patient we actually had at Children's about 3 years ago, in which you can see the liver is essentially replaced by this large focal hemangioma. And this patient, in fact, did have tumor rupture, but after a long hospitalization survived, although the mortality for these patients is quite significant. So I just want to, again, reiterate that we at the Vascular Anomalies Clinic, we would be happy to see your patients if you have questions or just call us. But this is, as you're beginning to have an understanding now, this is a wide spectrum of diseases that we treat. Thank you for your attention.
So I'd like to turn our attention now to treatment of lymphatic malformations. And when you see a patient who has a lymphatic malformation or a lesion such as this, I think that parents have questions, and I'd like to address the questions that parents have in this talk, and you as primary care providers have as questions as well. So the first thing that parents want to know, of course, is what is my child's lesion? What has caused it? Is it benign? Is it something to be concerned about? What can be done about it, and what is the prognosis? As primary care provider individuals, I think your questions are, what is the pathophysiology? What are the clinical features? How do we distinguish these lesions from some of these other ones that we have seen today? Is imaging necessary for all patients? Are other organ systems involved? And what are our indications for treatment and our options for treatment? So most lymphatic malformations are present at birth. Here you see a child who was diagnosed in utero with a very large cervical lymphatic malformation, and the child was delivered via an exit procedure where a shoulder and an arm are delivered, and the child is intubated before fully delivering the child. 2/3 are present at birth, but some can present even in adults, such as this gentleman who has a cervical lymphatic malformation as well. The ones that do not present at birth, they usually present by about 2 years of age, and they often first occur after an upper respiratory infection. They can be quite alarming to parents. Most of them are in the head and neck, but they can occur anywhere, and here's an abdominal one, compliments of my husband. And they're usually isolated lesions, so we don't usually have to worry about multiple lesions. Why do these occur? Well, they are outpouchings, the lymphatic start is outpouchings of the venous system. And if the lymphatics fail to maintain their communication with the venous system, they sequester themselves off and then accumulate lymphatic fluid but fail to drain. And they're often associated with abnormalities of the vein, the venous system as well. And here we see a very dilated internal jugular vein adjacent to a cervical lymphatic malformation. When you palpate these lesions, they're soft, they're doughy. They usually do not involve the skin, although it sometimes may have a bluish hue over it, but certainly different than the vascular malformations and the hemangiomas that we have seen this morning. They can transilluminate, but only if they do not have septations in them, and we'll see the difference in some of the imaging studies. There's a staging system for cervical disease, and basically if you have a unilateral lesion that is low in the neck, the patients do far better than bilateral lesions that are above the hyoid bone and below the hyoid bone, such as this baby who died actually of sepsis as a complication of the lymphatic malformation. Even superior to the staging system is the classification system, and this is very, very helpful to determine the best treatment and the prognosis for treatment. We divide lesions into macrocystic lymphatic malformations that are singular or several very large cysts without septations versus microcystic lesions that have very small components and very small cysts. These are much more difficult to treat. The old terminology for this lesion used to be lymphangioma. The old terminology for these larger multi or single cysts or larger cysts is cystic hygroma. We no longer use this terminology. We call them lymphatic malformations, either macrocystic, microcystic, or mixed lesions as shown here. Imaging studies are very helpful. Ultrasound is very helpful. It shows us the size of the cysts, it's diagnostic, and it can even show us if there's blood flow within the cyst itself. But the problem with ultrasound is that it does not provide much anatomic detail. So if we want to treat these patients, we like to know more about the anatomy and the extent of the lesions. And this is where CT and MR studies are particularly useful. Not only do they define the type of the lymphatic malformation, but they also define the extent. And here are two images, a CT and an MR obtained from the same child 2 years apart, and we can see a large lymphatic malformation here. And if we look at the MRI, it gives us great detail about the macrocystic component and the microcystic component. Advantages of the CT are that it's very fast, so it can often be done without sedation. But the disadvantage, of course, is that it's associated with radiation exposure. And MRI is not as quickly done and usually requires sedation or a general anesthesia in younger children to complete. Both MR and CT can be combined with angiography, and here we see a large cervical lymphatic malformation deviating the trachea. And when we look at the MRA, the vasculature is all normal vasculature with no vascular blush in this area, confirming the diagnosis. So what happens to these lesions over the course of time? Do they involute? Yes, they do. But it's a relatively small percentage that involute spontaneously with no therapy. This is a hard thing to say because it's difficult to do a longitudinal study and contact patients from the last 20 years where they were first diagnosed with a lymphatic malformation. But the estimate is approximately 15% at most will spontaneously involute. The ones that involute most likely are the macrocystic lesions. And often after an upper respiratory infection, parents may come in and say, boy, that lymphatic malformation has diminished in size considerably after the recent cold that the child had. These do fluctuate in size. They fluctuate in size with colds, but more importantly, they can suddenly rapidly enlarge. And this is always very, very worrisome to parents and to us as physicians because sometimes the enlargement can compress adjacent structures like the trachea and cause problems. Enlargement arises if a child has hemorrhage within a lymphatic malformation or if there's infection within the lymphatic malformation. We always start these patients on antibiotics no matter what the cause because these lymphatic malformations, if they enlarge, can become infected and they can be very, very serious infections for the children as I showed you in the last several slides ago. Sometimes we aspirate in order to relieve the pressure. A lesion that has recently hemorrhaged into it will have bloody appearing fluid. It's still very thin, but it is colored brown or reddish in color. So treatment options for these lesions are fourfold. Observation is certainly acceptable for small lesions that are asymptomatic as long as the parents understand that the lesions can become infected and might need therapy. But observation is reasonable. Most patients who have very large lesions like this, the parents would not feel that observation is acceptable, obviously. Aspiration is not very effective. The lesions recur pretty quickly in the vast majority of cases, sometimes in the recovery room after aspirating the lesion in the OR. Surgical excision has long been our mainstay of therapy. The problem is that it's very difficult to remove these lesions completely because they insinuate themselves around vital structures, and if you leave any bit of a lymphatic malformation behind, the likelihood that it will recur is very, very high. Additionally, the risk of nerve injury in these young infants, again, the lesions wrap around nerves, the risk of nerve injury is high. So because we as a group of physicians have not been happy with surgical excision over the course of the last several decades, we've sought other means of therapy, and sclerotherapy is a very, very great means of therapy. I should point out that this patient was referred to us after an outside physician excised the lesion, and you can see this young infant, it recurred very quickly after the near-complete excision. Sclerotherapy is particularly useful in surgically challenging areas such as this lesion in the infratemporal fossa, very difficult to excise and maintain good contour and preservation and neural structures when it is this deep. And here we can see the patient was treated with sclerotherapy and complete resolution of the lesion. There are many different sclerotherapy agents available. They are all used as either off-label medications or investigational drug agents. We like OK432. It has a very interesting history. It's from group A strep pyogenes that's been pre-treated with penicillin, and it was first used in the 1960s, thought to be very beneficial as a chemotherapy agent in Japan. It had no effect for the efficacy of lung cancer. However, what individuals did notice is that if the patients had malignant ascites or pleural effusions, they were sclerosed by the therapy. So this physician, Dr. Shuhei Agita, who died several years ago from a heart attack at a relatively young age, did excellent work utilizing this for treatment of lymphatic malformations. And he came as a visiting professor in the early 1990s when I was at the University of Iowa, and we were so impressed by his results of treating over 400 patients in Japan and Mexico, where he did a lot of volunteer work. So we eventually, my partner Richard Smith, and I eventually gained FDA approval to use the medication in the States, and it was initially used for over 150 patients, very effective. The pharmaceutical company does not want to spend the expense to get it FDA approved, and the FDA has kindly allowed us to use it under the IND number. It's easy technique to perform under general anesthesia. We localize the cyst, we aspirate the cyst, inject the medication. Patients sometimes need an average of 2.3 treatments over the course of time, and we space them apart about 2 months. Patients always have a fever for the first several days afterwards. They always have severe swelling, which can be quite alarming, which typically goes down over the course of the first 2 to 3 weeks after therapy. When we look at trying to figure out which lesions respond to OK432, we find the most likely predictor is whether it's a macrocystic or a microcystic lesion. Very good response for macrocystic, very poor response for microcystic, and a mixed response for mixed lesions. Another example, very difficult lesion to treat. It extends very far superiorly and inferiorly. OK432 is utilized, and you see that she has complete resolution of the lesion. Another example, pre-treatment, very large lesion, post-treatment. The microcystic lymphatic malformations are a little more difficult to treat. They're often in the oral cavity, and here we can see we can just treat the surface with laser or coblation, and it nicely heals over, and this relieves the patients of their complaints, which are typically bleeding and pain with eating. This is a child with a very large microcystic lymphatic malformation, very difficult to treat, not amenable to sclerotherapy, so surgical excision is our main modality of treatment. She underwent a 16-hour operation to identify the facial nerve in this area, all the branches, remove the microcystic lymphatic malformation superficial and deep, and her contour is much improved, and then we will treat this area this summer. So in conclusion, macrocystic lymphatic malformations, our treatments are surgical excision or sclerotherapy, and microcystic lymphatic malformations, our treatment options include observation and surgical excision. And quickly, I think we have 2 minutes for case reports. Are there any questions I should ask first? Okay, 3-month-old infant, swelling right cheek for 1 month, growing rapidly. So all of us in our mind have a differential diagnosis of what this could be: hemangioma, venous malformation, lymphatic malformation, or even perhaps a neoplastic process. We obtain a history. Hemangioma is also present on the forearm, appeared at a similar time. We examine the patient. It's soft, it's spongy, not fully compressible like a venous malformation, does not transilluminate like a lymphatic malformation. And are there additional studies necessary? A Doppler study helps us to assess the flow and confirm it's a hemangioma. Imaging studies for parotid lesions like this are not necessary because the history is so consistent with what it is. But if there's any concern that it's not behaving like a hemangioma, by all means we would obtain an imaging study. 6-year-old boy who presents with a painless swelling of the left helical rim, present for approximately 4 years and just gradually increasing in size. Our differential diagnosis, since we're at a vascular talk, a vascular lesion, post-traumatic lesion, or a neoplastic process, benign or malignant. When we performed the physical examination, as Phil said, a thrill was present and the lesion was warm to the touch and rather soft, but had rebound refill as well. The presumed diagnosis is an AVM, so our treatments will be observation. If we observe it, it will gradually enlarge over time, so we feel it's better to be proactive while it's still surgically or treated with surgical therapy. And this child will undergo an angiography to assess the feeding vessels, will undergo embolization, and then will undergo excision. Very difficult to remove these lesions completely because there's often a little bit of nidus tissue beyond the lesion that you see, and it must be removed completely without causing a cosmetic defect to have a great outcome. And finally, 5-year-old female, left neck swelling since infancy. Outside biopsy was done, showed it was benign. It was soft, partially transilluminated, didn't compress. And here are the MR studies, most consistent with the lymphatic malformation, a microcystic component, as well as a macrocystic component, treated with sclerotherapy, and a very good outcome. All right, thank you very much.